Welcome to the first AO Spine webinar of 2021. Thank you for joining us. My name is Ali Baj from the University of Arizona in Phoenix, and I'm absolutely pleased to be moderating this session with two outstanding friends, colleagues, and really expert surgeons. With me today is are Dr. Eric Kleinberg, who's professor and vice chair, adult and pediatric spinal surgeon in the Department of Orthopedics at UC Davis in Sacramento, California. Also with us is Dr. John Shin. He's the director of spinal oncology and spinal deformity surgery at Massachusetts General Hospital and Harvard Medical School in Boston, Massachusetts. So thank you to both for joining us this evening. These are the disclosures. None of what's listed here will impact these cases that we will show on spine tumors. A few housekeeping rules here. Upon completions, the participants, these are the learning outcomes. The goal is really to describe some of the changing paradigms in spinal tumor, metastatic tumor disease and treatment, talk about some classification systems, and also recognize the indication for various options. The overview, again, you will see some excellent case-based discussions here presented by Drs. Shin and Kleinberg on spinal metastases. And here is the agenda. We're going to get to the cases pretty quickly here. Dr. Shin will start, and this will be a discussion and debate interactive style between all three of us. I encourage all the participants. We're fortunate to have all of you with us tonight. We're probably going to have around 140 or 150 participants, which is excellent. Please use the Q&A panel. Use the Q&A panel to type in questions, and the faculty and myself will do our best to answer those in a timely fashion. So we want this to be interactive. We want everybody to be involved, but go ahead and use the Q&A panel, not the chat box, please. So just a quick word about some upcoming AO North America spine webinars. As all of you guys know, these are some of the most excellent, really educational initiatives out there. So this can be found on the AO Spine website, but some excellent webinars coming up for 2021, and we highly encourage everyone to participate. But without further ado, we are going to talk about the topic of this webinar, which is spinal metastases. And we're going to show some cases and talk about what the operative and non-operative options are. I'm going to show a few slides, introductory slides here for everyone, just to set set some background here. We all know that surgery is effective. We all know that there is an important role for surgical interventional spinal metastases management. This was born all the way back from the famous Patchell study that we hear about and we talk about. And we know that there is added instrumentation and stabilization does improve outcomes in patients. But here's a scenario that this is exactly what we're going to talk about. This exact picture here, this MRI, the patient will be treated differently depending on the patient's age, comorbidities, extent of tumor disease, and most importantly, the pathology, whether it's myeloma or breast or renal or primary, which is not, it's beyond the scope of this webinar. But this is why this topic is so important, because the MRI can show one thing, but there's so many factors that are involved to treating that patient. And that's exactly what Drs. Shin and Kleinberg are going to elucidate for us. So here, I do want everybody to know, and I know you do, but these are some of the classification systems and some of the frameworks that many of us utilize as we evaluate and manage patients with spinal metastatic disease. The NOMS framework, which involves neurological, oncological principles, mechanical instability, and systemic disease, we use that to help us guide treatment. And we also have, of course, the SINS score, the spinal instability neoplastic score. We're all familiar with these. Excuse me, I'm not going to go in great detail, but these are tools that we use to quantify some of these conditions that we see. And of course, they're important to communicate with each other and across both clinical and academic circles. The Tokahashi score, that's been around for a very long time, that's a prognostic score. If you treat patients with spinal metastases, you know that you utilize this. But the bottom line is when we consult oncology and we say, hey, before we operate on this patient with spinal metastatic disease, what is the prognosis? What is the life expectancy? Because we don't operate on somebody who just has 2 or 3 weeks of life expectancy. It's not fair to them. But the answer is always the same, right? It's always the same. It's greater than 6 months, greater than a year, and the onus is back on you as the surgeon to have that holistic understanding of the patient, discussion with the patient and the families to make sure that we're doing the right thing. We're not over-treating, but we're not under-treating the patient with spinal metastatic disease. One of the most common conditions we all see, I personally think it's still one of the most challenging conditions because it truly is case by case, regardless of all of these beautiful frameworks and classification systems. That's why this webinar is so important. It's an important topic. It's a ubiquitous condition. And again, we're honored to have our 2 guests today. And I'm going to go ahead and stop sharing my screen. And Dr. Shin, if you don't mind sharing yours, and we will start with your cases.
Great, thank you very much, Ali, and it's great to be here. Can everyone hear me okay? It's hard to know, there's no live feedback. So, but it's a real pleasure to be here. Always to see great friends and colleagues, Ali and Eric, but also thank you to AO for hosting and inviting us to this webinar. So like Ali mentioned, we're gonna bring up some cases and really want this to be interactive. And please ask questions. You can tell me that I'm doing it wrong or that I'm really off base, or this is meant to be educational and also confrontational in a good way. So let's get started here. So when we think about metastatic disease, I just have 1 or 2 background slides just to really emphasize what Ali mentioned, was that we have to think about the goals, right? And I know that Eric is going to talk about some more invasive strategies, but when we're talking about metastatic disease, we've got to think about this is mostly a palliative situation, patients with end-stage cancer, not something like a primary tumor. So we think about their function, stability of the spine, obviously pain, quality of life, but also tumor control. Whatever we do as surgeons, we don't want that tumor coming right back. And so just like Ali mentioned, we have the NOMS paradigm. And I think one of the things I just want to emphasize is that we're pretty good now at thinking about the neurology, right? So whether you're a neurosurgeon or orthopedic surgeon, we're good at thinking about the neurology. We understand the radiosensitivity of these cancers. And now with the SINS score, we can think about stability. But we have a lot of trouble with thinking about complications and the invasiveness of surgery, and is that patient really going to survive? Okay, so here's the case. This is a 64-year-old, has non-small cell lung cancer, EGFR positive. For some of you, that may mean something. For most of you, that probably means nothing, but that's okay. This person got 30 gray of radiation previously to the spine. This is at the T2 level when there was a little bit of tumor in T1 and T2. So this patient got fractionated radiation for that. Also had a history of radiation to a lung lesion with overlapping fields, has other bone metastases, has failed several lines of chemotherapy, now on immunotherapy with some progression, some places, stable disease elsewhere, with expectancy of about 6 months. maybe 12 at the most, about 6 months. But this patient's coming in with severe neck pain. They can't keep their head up, now having difficulty ambulating, still having preserved strength in the legs, barely anti-gravity, let's say just about 3 out of 5, but otherwise was ambulating, doing fairly well with this burden disease. So what do you think? What are our options here? And what do you think about this? Ali, what do you think about this case?
Yeah, thank you, John. This is excellent. This is exactly what we're here to discuss, these challenging cases. I mean, so the first thing for me, literally the first thing for me when I evaluate a patient with spinal metastases is what you have at the beginning and at the end. How old is the patient? What is their life expectancy? That tells me a lot. An 85-year-old with 3-month expectancy is going to be treated differently than a 40-year-old with more than 1 year. So there is neural element compression. There appears to be a pathologic fracture. The patient had undergone radiation. For me, in this case, this is a surgical lesion. Now, two things here. Surgical meaning what? Do we just decompress? No. I prefer decompression and stabilization. The big question is do you do separation surgery or do you do full circumferential corpectomy? And for me, that depends on the extent of metastases. Patients with multiple sites of metastases in their bone or liver or lung, I'm going to be less aggressive. Decompression, separation style surgery with stabilization to help with the pain, because stabilization does help patients with pain, no question about it. That's what I would do. I would do a limited separation surgery with adjacent segment stabilization in this case.
Okay, great. Eric, what about you? What do you think? I mean, would you consider doing an anterior approach? This is at T1, T2. If you were going to do a corpectomy here with fixation at the upper part of the thoracic spine, get enough visualization there. I mean, I mean, would you even consider that, or what do you think?
Yeah, I would probably split the sternum. Then I like to move the heart out of the way and go from the front. I'm kidding. I would never do that. It's just I think that I think you want to temper your surgical insanity for what the goals of treatment and therapy are. So again, this is metastatic disease. You are not going to cure this patient of cancer. The good news is that they're EGFR positive, so they've got good survivability. We've got good targets for that now, so that's a good sign. What we need to do is you need to think about how. So it really depends. This guy's neurologically, this is going to be a problem for him, right? And so we need to think about something about decompressing the canal, giving him some stability. And he's had radiation in this area. I'm worried about wound healing. I mean, you have some real issues here. But I think actually the surgical decision making is pretty easy. This guy needs a posterior only approach. He needs a costotransversectomy. You need to reach around. I have found, I love the idea of separation surgery, and I love this idea of like, just taking out what I need to take and leave the rest alone, and then they come back and they radiate it. But in my experience, the only thing that's suckier than doing a primary metastatic case is doing a revision metastatic case. And so I want to do the best job I can. If I'm there, I probably do a complete, remove this whole thing, scrape everything back, place a cage in there, give it some good stability and get out of Dodge. And I'm a little bit more aggressive the first time around, so I don't have to go back. I think about, the things in this case are going to be, what other metastatic disease locations are they? You need to look at the whole spine and don't get too myopic and focus on one area, because sometimes you can miss drop mets. The other issues, I think wound healing, and this is going to be a big issue. 30 gray is not terrible, but I still, they got that plus another thing, plus a little cachectic. You might want to think about your plastic surgery buddies and see if they're around and help you close that thing up.
Yeah, no,
Eric, I'm sorry, John, to interrupt. Just a quick question for Eric and John, since both of you are live right now. There was a good question about the metastatic workup. We all know to get the neuroaxis MRI, chest, abdomen, pelvis, or PET scan if you're an outpatient, I guess. How many of you additionally get a brain MRI when you're doing a metastatic workup? Say it's an inpatient consult. You have the cervical, thoracic, lumbar, chest, abdomen, pelvis. Do you guys routinely get add a brain MRI or not?
I don't typically do that as a comprehensive if I'm thinking about surgery. A lot of times those patients will either have known metastases or they would have, they may have had cranial imaging in the past several months. But I think if someone's coming with a primary spine problem that I know is metastatic and they've got a critical neurologic issue like this patient does with cord compression, whether they have one brain med or three or five, it's not going to really change my decision making in terms of, taking care of that cord compression and impending paralysis.
Yeah,
Thank you.
I would say I'd like to look at the neural axis. Typically, the cervical spine will give you a pretty good look in at least the base of the brain. Maybe it doesn't give you the full brain, but you should be able to tease that out on exam, whether or not they've got symptoms. And then I also think about what their disease burden is. So lung cancer, brain mets, they happen, but they're a little more rare. Myeloma, I'm more aggressive about looking at the brain because I worry about skull mets, et cetera. But I agree with John. I think I try to take care of the problem. I always get an MR and a CT scan though, because I really want to assess the bony integrity. I think sometimes that gets under recognized. And then I saw there was also a question in the chat about like, hey, there's 6 months, why do a big surgery 6 months? But John is tricking you here. So don't fall for it. So he's saying the life expectancy is 6 months. I will promise you there is no oncologist that can tell you what their life expectancy is, plus or minus, I'd say a year. They're off one way or the other astronomically. And with these EGFR positive patients and the new targets that we have and the new, I've seen people who were supposed to last 2 months and they come back 3 years later. And so just be careful with the life expectancy stuff. I'd say that is wrong as often as it's right.
Yeah, that's a great point. I mean, I think that, I mean, Eric is so smart. I mean, I really can't say anything more than that, but I think that, I think that you're right. I think as surgeons, we write a lot of papers, we study this, we think about complications, we think about frailty, we think about survival, but you know what? You have to think about it from the medical oncologist standpoint. I think one thing that like we as surgeons need to keep in mind is that in all of their clinical trials looking at these molecular receptor inhibitors or immunotherapy, a lot of times patients with bony metastatic disease and spinal metastases are excluded from those randomized studies. Those patients are excluded from those type of protocols. And so when patients are in these situations, like no one really knows how they're going to respond. And I think that's where, that's why it's so difficult, but I agree with Eric. My approach here was posterior approach, separation surgery. And I think to clarify the term separation, I don't mean just do laminectomy and just kind of suck some tumor away. I agree. I go down the pedicle bilaterally. I carve out as much of the vertebral body as possible. I take down that posterior vertebral body wall, the posterior longitudinal ligament, and I'll show you a picture of that in a second. But I think it's really important to circumferentially really go around and decompress the spinal cord. And I think in terms of really vascular tumors, like if this was renal cell, sometimes it just bleeds a lot and it won't stop until you get a lot of that marrow out. And so I think that, you can think about doing a limited sort of decompression, but oftentimes the reality is that once you're in there, it's very hard to stop because the marrow is bleeding and the tumor sort of delivers itself. But I know we have to move on, but
John, I was just can I add just one thing quickly to that too? A lot of times too, these tumors are fairly vascular, no matter what they are, and the bleeding does not stop until you take all the tumor out. And so the tendency I've seen, particularly with surgeons that are just starting, is you get the bleeding, then you stop and you get nervous and you try to pack it off. But for these tumors, the best thing is take it all out. Once you take out all the tumor, all the bleeding stops. So it's kind of amazing. Sometimes you have to stay aggressive to be safe.
No, absolutely. And I think, thinking along the gnomes paradigm or whatever algorithm you're thinking about, this patient obviously has a pretty unstable spine, anterior posterior column involvement. You can see where it is. It's a junctional location. They're clearly having pain that's mechanical, lytic lesion. There's no deformity here, but again, this is an MRI. I don't have the standing x-rays. You can see here there's pretty extensive involvement. So, this is just a video of what I think Eric wanted to do, was do a pretty extensive sternotomy here, just showing kind of what's involved. I think he does this. I think this is his approach for ACDF, but but this is. I don't know if you want to do this on every patient, but
Oh my
I think
gosh.
we don't have to do something like that. And I think because of the EGFR positive, I think, not to get into molecular biology, I think as surgeons, we don't really delve into that, but you know what, we do understand that these molecular cell types, they do matter now, regardless of what you're looking at, whether it's melanoma, lung, or renal cell. So it's important to think about. And, at some point, this may affect how we decide to operate on these patients, just like Eric mentioned. We know that thoracic laminectomy, not so great, right? We know that from Ed Benzel's work, biomechanically, kyphosis begets kyphosis. And the posterolateral approach works really great. A number of people have shown that. And that's what I did here. And this is just an intraoperative photo showing what that separation looks like. So right in the middle there, these two large holes here are basically the pedicles of T2 have been taken down, that cavity, essentially an intralesional vertebrectomy performed from a posterior approach with fixation above and below, nerve roots completely skeletonized with resection of the tumor. And this patient underwent stereotactic radiosurgery afterwards, then resumed immunotherapy right away. I don't wait, we just start them right away. Really does not impact wound healing at all. And this patient ended up surviving for more than a year. And this is the post-op scan. So this is what we want to see. We want to see that CSF signal restored ventral to the spinal cord. And you can see here that this is kind of where the work was done. It's a post-op MRI, and you can see the contour of that spinal cord. It looks really nice. You can see the defect posteriorly. And on the post-operative CT, you can also see sort of the extent of that intralesional vertebral body resection, taking away most of the marrow. I did not reconstruct it. I just, had fixation above and below with cervical lateral mass screws and thoracic pedicle screws. And essentially that patient gets stereotactic radiosurgery and with local tumor control and no recurrence. So that was my first case, but Ali, it's already 8:22. So I don't know if you want to jump to Eric or how you want to proceed.
Yeah, thanks, John. Well, you put together some introductory slides, which are out of the way. I think we should just go ahead real quick for your second case.
Okay.
Maybe about 5 minutes or so. Is that okay,
Yeah.
Eric?
Yeah, of course. Sounds great.
All right, let's do 5 minutes for the second case.
Okay.
Great first case.
Okay. So here's my second case. It's a 47-year-old woman with metastatic breast cancer who comes in basically hospitalized for severe back and left leg pain. When I saw her, she was basically on a ketamine drip on the floor for about a week. She couldn't move and couldn't even stand or sit because the pain was so horrible. And she would kick her legs 5 out of 5, pretty strong ones while she's in bed, but when she stood up, a lot of pain. And you can see here there's L4 pathological fracture, retropulsion, and I'll show you the axial here. Pretty extensive retropulsion there and foraminal extension of that disease, primarily on the left side. And you can see the CT there also with evidence of destruction there. So,
hey, John, what's up with that weird dura down below?
What's that?
Look at her MR. Go back to one slide and then on her MR.
Yeah.
What's up with her dura down there? Looks weird to me.
I think you mean the enhancement there?
Yeah.
Yeah, I don't know. I think we see that quite often. I mean, sometimes it's hard to know whether that's yeah. I mean, it could be. It's always hard to interpret whether that's meningeal enhancement or you know, some venous, contrast enhancement. Hard to know, but I agree.
Yeah. Okay.
So this lady had a sin score of 13, okay? And the question becomes, now what do you want to do? Perk screws, augmentation, open, MIS, vertebrectomy, separation surgery. And I put these axial sections up for a specific reason. Ali, what do you think?
Yeah, I mean, it's same thing. So young lady. How diffuse is her tumor burden systemically?
She's got metastatic breast cancer, but disease is pretty well controlled. But like a lot of breast cancer patients, there's just sort of mixed lytic blastic disease throughout her spinal column,
Yeah, and do you think, I mean, so that is the pain generator, and so she has back pain and no neurologic deficits, is that right?
No deficit, but just pain specifically in like a L4, L5 distribution on the left.
Yeah. Yeah, I'll tell you, I've kind of adopted for these types of cases where I don't need to necessarily do a decompression. I'm very, very happy doing a MIS perk stabilization with intraoperative vertebroplasty at that level. I think that's from a risk benefit ratio, it's less than an hour in and out. So I don't mind doing perk stabilization with vertebroplasty in this case.
Yeah. Eric, what do you think?
I like Ali's plan. I don't like these pedicles though. They're little wispy suckers, and so this may be a tough perk screw case just because of how narrow those pedicles are. So that would push me a little bit more towards doing something open, just because
And this is my plug for navigation, Eric. This is exactly what I say. Intraoperative navigation is awesome.
Yeah. Well, and that may very well be right. Maybe with newer technology, we can take these difficult pedicles and make them easy pedicles. But these would be a little bit challenging. I think what she needs is stability. I probably wouldn't even muck around too much with the cancer bit, just because breast cancer is so radiosensitive that you should be able to get stability with nice radiation, and she'll get whole beam stuff. And so I'd probably get her some stability and like Ali said, get her on and off the table fairly quickly.
Okay. So I'll show you how I approach this case. Yeah, my concern here was I definitely agree. She definitely had a mechanical component. She had this mechanical radiculopathy with anytime she really got vertical, she'd have this horrible leg pain. And that really precluded her from walking. But then I saw the size of these pedicles here, and this is sort of what it looked like up and down, and so I was really concerned about doing a big open or MIS multi-level with tiny pedicles like this. I have a little less faith in navigation than you do, Ali. So, I thought that would actually be more morbid. So I did this actually through a mini open lateral retroperitoneal approach. This is with the patient with the right side down, left side up. And you can see here, these are just some of my surface markings here, just with fluoro mapping out kind of where I want to be with the iliac crest and where the vertebral bodies are. Then I use a syn frame retractor just to go down, almost just to like doing a lateral, but with a mini open approach. And here you can see I ended up doing an intralesional vertebrectomy to visualize the ipsilateral and contralateral nerve root there. And to make sure that nerve root was really free, because she was having a lot of symptoms from the foraminal compression. Then reconstructed that using an expandable peak cage with a cement augmentation with fixation, anterior fixation with screw and plating. That's sort of what it looks like there. This, like you said, Eric, this patient got external beam radiation afterwards, had complete resolution of her back and left leg pain, and survived more than 2 years after this operation. Ultimately, obviously succumbed to systemic cancer burden, but at least from a spine standpoint, she was able to get up, moving around, and really increase her pain and quality of life.
Money.
Yeah, that was fantastic. Thank you, John. We'll go ahead and switch over to Dr. Kleinberg's talks. Yeah, that's a really nice, elegant way of doing that, John. I know one of the questions was about decompressing that contralateral side, but my thought is I just answered on your behalf, if you don't mind. My answer was, well, if somebody's having severe radicular pain, you're probably going to go either on the ipsilateral side or you're going to do a direct decompression, correct?
Yeah, that's right. And honestly, I think, well, at least, for me, when I do these vertebrectomies, I like to see both nerve roots, and especially on the contralateral side, take down that pedicle. But I think, someone had asked, what about SRS and vertebroplasty? For me, it's like that patient had really significant radiculopathy with weight bearing. And that's just something that it's just rolling the dice whether radiation is really going to palliate that. And I just know that when we take the pressure off the nerve, that leg is going to feel a lot better. So,
Got it. Thanks so much, John. Just a quick reminder, guys and gals, for everybody who's with us, 170 plus people. Thank you so much. Make sure you stay at the end. In order to receive the CME credit, you do have to complete a survey at the end. So the survey is at the end, gets you your CME credit. Please stay with us to the end to complete that. Dr. Gleinberg, the floor is yours.
Wonderful. Well, I'm glad that everyone could take some time from storming the Capitol to join this webinar. That's really great. So we'll, keep in the same vein. I think a lot of these, just to follow up on a couple of points. Number one, I think you really have to think about the patient and have a frank discussion with the patient about what they want and what their needs are. Just like Ali said in the beginning, one size does not fit all. And so you really need to be thoughtful about what you're doing and who you're doing it for. And some of that is about the patient's fears, and some of that is about their survivability and their cancer burden and all the rest. So just keep that in mind. This is a case, a patient of mine, 39-year-old, so young female, had cervical cancer, had a hysterectomy about 8 years ago with negative 5-year surveillance, and then came to the ER with acute on chronic back pain and worsening right radicular pain. Worsening pain with ambulation, no bowel bladder dysfunction, and endorses about an 18-pound weight loss, and has some real weakness on her right side, maybe 4 out of 5 strength and a couple of dermatomes. And so here are her initial x-rays. And so I don't know how many of you have seen a winking owl sign. But John, can you see that winking owl? John, do you see that?
yeah, I'm trying to look at it. I see something there at L5. Is that right?
So you can see this whole, so you can see a pedicle here on this left side, and on the right side, you just essentially don't see anything. So this is a winking sacral ala, and so you don't see part of the ala. When you see this, you say, gosh, I want some more imaging. So here you go. Here's an MRI. And so here's the study that we got. You can see we got everything looks fine, L2, L3. And then when we started getting L4, we have this very large lesion involving the majority of the sacrum and ala. Looks like the ilium is spared, but there's significant involvement there. And then, forward there. And then I know you guys are going to want a CT scan. So here I loaded up a CT for you here as well. And you can see significant bony destruction, large tumor burden. And again, just some definitive cut to those areas. So bone scan, she's got some increased tracer activity at L5. Everything else looks pretty benign. No other disease. CT scan of the chest is negative. And so we got a biopsy. So found some metastatic squamous cell carcinoma, which is classic for this metastatic spread of this cervical cancer. So, John, what do you think? Goals of surgery? What do you want to do? I know how you like taking these big problems and knocking them down.
Yeah, I think that's a difficult case. I mean, that's at a, first of all, I think the patient's having a lot of mechanical symptoms, and we know what the cancer biology is there, and I think the real issue is what can radiation do for that patient? Did that patient get radiated, Eric? I may have missed that.
So no treatment, has not been radiated yet, has not had any other chemotherapeutic. This is a new diagnosis, and the mainstay treatment for a lot of these cervical cancers is going to be chemotherapy, so some sort of Taxol derivative. And she was, when we met her, she'd gotten the diagnosis. She was presented to our oncology team. And she couldn't get out of bed. She was just lying in bed, and every time she would sit up or try to do any sort of transfer, she just had excruciating pain, and couldn't do anything.
Yeah, I think these are very difficult situations to palliate with radiation alone. The question really becomes, what type of surgery and how extensive do you want to be with this? Because, I think that if you just chase this from a posterior approach alone, you're going to end up in a deep, dark, bloody hole in the retroperitoneum. And I think that there are a lot of structures there that when we do anterior approaches like ALIFs, if it's, we're not seeing a lot of that anatomy. And especially if you're not used to doing a lot of cancer surgery, there are a lot of vessels and the ureter, a lot of other things in there that will get in the way. And I think that what that CAT scan shows is that bony destruction, the sacrum goes all the way to the sacroiliac joint, right? And yeah, and so it's almost like that patient has a disconnection between the pelvis and the sacrum.
Yeah, that's exactly right.
On that side,
exactly
yeah.
right.
Yeah.
And you can see that, and you can just imagine how much discomfort that causes. Ali, thoughts about what you want to do?
Yeah, I think a great case. I think that the key, as with all these cases, is really treating the patient's symptoms. Are they neurological? Are they mechanical? Or are they both? If the main issue is the mechanical that I know I can fix with stabilization, whether perc or open, and whether the biology of the tumor lends itself to a positive, at least reasonable treatment with or reasonable response to chemotherapy, I have no problem doing that. So that's a discussion multidisciplinary tumor board in which I can offer, again, perc or open stabilization, and then see what happens to the tumor with the adjuvant therapy if the consensus is it's responsive to radiation therapy. So I'd be interested in that discussion. What did they think about this type of biology and its responsiveness to systemic therapy or radiation? She's definitely going to get stabilized, lumbo-iliac stabilization for me, no question about it. The question is what do we do about the tumor? Depends on how responsive it is to systemic or radiation therapy.
Yeah, it was as you can imagine, there's a lengthy kind of discussion. Here was kind of my thoughts. In general, we think about survival rates for cervical cancer. If the 5-year survival rate, if it's local disease, it's about 92%. With this distant, and so this is technically distant metastatic disease, and so her survival rate is very, very low. It's about 17% at 5 years, and so poor prognosis, poor disease. She's got recurrent cancer with metastatic spread, has a high mortality rate, but any surgical resection, like John said, boy, front back tumor resection, nerve roots in the breeze, putting some sort of crazy iliac thing, that also has high morbidity. But I'm also faced with this patient that has severe mechanical back pain. I've got 2 oncologic partners, and so one of them said, please help this lady. She needs some sort of stabilization. The other one said, please don't do anything. She's not going to survive long enough, and we don't want her to be recovering from your surgery while she does that. And so it was difficult. So I went and sat with the patient and her family for a bit and kind of said, hey, listen, what do you want to do? I can't cure you of cancer. What I can do is maybe give you some additional stability, and maybe that lets you walk out of this hospital but it's going to be a long road to hoe. And so ultimately what we decided to do was to stabilize this, to not do any tumor excision or debulking, and really expedite the chemotherapy, which is likely the only thing that's going to have any survivable difference for her. And so our plan was to put screws above and below this lesion, kind of give it some stability, really not mess around with the tumor. I didn't want to get, sometimes, I don't know what your experience is, but sometimes I go in there trying to debulk a tumor, and all I do is I get it really excited, and then it grows astronomically once I muck around with it. So I'm usually fairly, if I can resect it, I try to resect it. If I can't resect it, I usually don't try to do a partial resection, just because I think the recurrence rate is so high in those. And so here's intraoperatively, we place those screws. I did this in a semi-percutaneous manner. She was kind of a bigger gal, so I made a real incision on her back, but then I tried to leave the muscle envelope intact. And then here's her final stability. And you can see that these are standing films. When she came and saw me in clinic, she's still has significant discomfort. We didn't cure her of her pain, but she's certainly feeling a lot better. We transferred her immediately over to the oncologic service, and she started getting her cisplatin and Taxol. She's now on her second dose. And they're going to start doing some VEGF inhibitors and immunotherapy. She still has some mild 4 to 5 weakness in her leg, but she's walking unassisted with an AFO, without an AFO, and doing actually surprisingly well.
Yeah, Eric, that's a great construct and a great result. I think that I think it was fortuitous that you actually had enough bone on that right side to put the pelvic fixation. I've had very similar situations where that osseous destruction really it traversed that sacroiliac joint, and then you're just like, what do you do? It's almost like you're just staring at the femoral head. I had a case of RCC recently, just like that. And we just basically radiated and gave that patient immunotherapy because there wasn't any good fixation option. And I just didn't think that a unilateral construct would work, So that's a great result. One question I have is, do you ever consider in the oncologic setting putting more than one screw into the pelvis?
Yeah, I would, yes, I think that's a great call. I didn't see any disease crossing that SI joint. So, and the bony purchase we got, she's 39. It was bomber bone. And so I decided not to, but I think double iliac bolts are a great call. If I had any question about stability, you could certainly do that easily. I tried to get her on off the table as quickly as possible, just because I really didn't want to disrupt anything. And I was so nervous about giving her any problem just from even this, this isn't that minor a surgery, right? It's a lot of screws and rods and stuff, but even from this, I think that's a great call.
Eric, that's fantastic. I'm going to ask you a question from the audience, which is from the participants, which is for both of you, John and Eric, your use of biologics and graft in patients with metastatic spine tumors. Can you talk about that a little bit? How it's different than, say, the non-metastatic patient? And Eric, did you have one more case, Eric?
Yeah.
Okay, great.
So the biologic discussion is easy, right? You don't want to use any off-label biologic. I think that's incredibly risky. You just have no backing in terms of what you do or how you do it. So that's an easy discussion. I don't think these things really heal, quite frankly. You take them, then you irradiate them. And so I think if you're looking for stable, long-term construct, a young patient that you're looking for a fusion, I'm a pretty firm believer in autograft. So I'll take iliac crest, or I'll take rib harvest and come up with a construct. I sometimes will sprinkle down some bone chips around stuff, but I'm never very convinced that anything actually heals together.
Got it. And John, I'll ask the same question to you. Eric, if you want to share your screen for your second case while John answers that. John, what's your take on graft material in metastatic spine disease?
Yeah, I do think it depends on what, that projected survival or where that patient is in their cancer history. We all see patients that maybe have a first time presentation of a renal cell met, with a concordant like kidney lesion, or, oligometastatic disease where they have very few areas involved of the spine, in which case I'll try to arthrodesis it like a usual case. But then if I'm taking care of a patient with really terminal lung cancer or metastatic melanoma that has failed immunotherapy, but they've got really horrible cord compression or other considerations. I think it just depends. And in those cases, I don't even bother putting down bone graft. I might just like, if it's in the thoracic spine, I might decorticate the facet a little bit, but it's all about stability. So in those cases, I use fenestrated screws. I put cement in. Someone earlier asked about carbon fiber. I use carbon fiber. I use whatever it takes to try to, add a couple more levels to increase the stability. But, I think over the years, I think these patients do come back, whether for adjacent levels or for recurrent levels. And every time I open it, I don't see that it's fused at all. It just looks like scarred down radiated tissue. So I'm not convinced that it's really that important.
Got it. Got it. Yeah, it reminds me of the old adage in metastatic spine treatment is immediate fixation is more important than long-term fusion because many patients will not live, unfortunately, to see that long-term fusion. So if your goal should always be, how can I get this patient stabilized in the best and most durable fashion, right? So we've got one more case here with Dr. Kleinberg. But Eric, I just want to say something about the last case, which I think is super, super important, especially for the trainees. Perhaps we have some, residents, fellows, and junior surgeons. I'll tell you, I always learn something when I listen to you speak. That's why you're always invited on anything I ever do. I mean, you're just phenomenal. The one thing that I absolutely loved about the last case is, and I think this is really important in this condition in spine tumor disease. You understood the biology. You actually did your research or know the research about the percentage and the prognosis. You didn't rely on oncologists, but you did your research. You know the biology. You talked to a couple of colleagues, and most importantly, it was a shared decision with the patient and their family. I mean, if anybody wants to pick up something from that last case, is just at least those four tenets. Not just MRI, decompression, fusion. Know the pathology, do a little bit of research, go out of your way to know what the natural history is, talk to others, talk to families and patients. That was really brilliant. So thank you for that. Floor is yours again.
Gosh, I'm blushing a little bit, Ali. I'm not used to that. All right. So John talked about renal cells. So we'll do this case. So this is a 51-year-old patient. Came and saw me, history of renal cell. In fact, he got a nephrectomy about 2 years earlier, and now comes in increasing mid-back pain. So, John, you know what we're getting to. Here's just for fun. I wanted to show you what his renal cell looked like in his kidney. So he had this, you can see this pretty big massive lesion in his left kidney. And then here he is after his resection, and all the urologists are high-fiving themselves, and then off he goes, and then comes knocking on your door. And so he comes to the ER, increasing back pain, can't stand for more than 10 or 15 minutes without excruciating discomfort. Does not have any neurologic issues, however. So no deficits, no weakness in his legs. Here's his MRI. You can see the hyperintensity on T2, hypo on T1. Here's a lesion involving almost the entirety of the vertebral body without significant disease in the posterior elements. Here's your CT scan as asked for. You do see there is some disruption of the cortical margin anteriorly and maybe a little bit posteriorly as well, but there's no disease that's gone into the area. He had a CT scan for the chest. This is the chest CT. There's no other disease. We don't see any other lesions in the lung or lung fields. And so this seems to be, as you talked about, oligometastatic disease, single site renal cell. Thoughts about treatment, therapy, John, Ali? Surgical intervention, no surgery?
Yeah, this is a great case. Eric, just refresh my memory here. What is the presentation? It's just back pain, is that right?
Yep, back pain, inability to stand up. He's been kind of suffering with it for the past 6 months or so, and now has gotten to the point where he can't, even sitting up in bed gives him a tremendous amount of discomfort unless his back is supported.
Yeah, I mean, I think that, when I see something like that, I mean, I think the classic argument is, do you like resect it and stabilize it, reconstruct it, versus, can you do something less invasive and administer stereotactic radiosurgery? I think looking at this, even though his history is suggestive of mechanical pain, you know what? It's mostly, I think, because that lytic portion is really taken over most of that vertebral body, but there's no clear fracture yet, that we can see, and nothing in the canal. So I think I would probably, considering where he is in his disease status, his overall function, disease burden, and the histology, I probably consider stereotactic radiosurgery versus surgery, coupled with possibly, cement augmentation either upfront or planned down the line in case that vertebral body fractures after treatment. But that would be my sort of initial thought on possible treatment for that.
Love it. Ali, any thoughts? Same idea?
Yeah, great case, and I agree with John. I mean, this can go, for me, solitary renal cell like this without a significant path fracture or neurological deficits is the equivalent of the grade 1 L4-5 spondy in degen disease. You can literally do 6 things, and probably none of them is necessarily wrong. As you know, Eric, in a lot of the debates in our national and international spine societies, we always have 2 people. On one side, en bloc spondylectomy for these. On the other side, separation or just stabilization and high dose stereotactic radiosurgery. The answer to this, in my opinion, and at least this is when I talk to people, it's very easy. It's not what you want to do or don't want to do. It's what's the institutional bias. What I do now is probably different than where it would be in an institution in which the consensus among the oncologists, radiation oncologists, is to do SRS, and I'm just talking about my days in New York. So the point is you have to treat these within the system, within the consensus, because otherwise you're going to be an outlier. So I know that's not answering your question, but I agree with John. This could very be well treated with stereotactic radiosurgery and observation versus, stabilization 2 above, 2 below, and a corpectomy with the cage reconstruction. And I think they're both right.
Yeah, that's a great point, Ali, totally, because you know what? If you're at an institution that does not have stereotactic radiosurgery and you're a new surgeon coming out of fellowship or coming into town, and you're just, you saw Ali Baj's webinar and you're like, hey guys, like we got to do stereotactic radiosurgery, and everyone's looking at you like, like you just, came off the boat, I mean, it's just like, so it really depends on where you are. And I would agree, if you had this and you're in Italy, you're probably getting an en bloc resection, or in other parts of the world, and I think that's a great point.
It's also interesting how these diseases change over time. A lot of the beauty of stereotactic radiosurgery is just how aggressive you can be with the radiation these days. And a lot of these tumors that we assumed were not radiosensitive just weren't radiosensitive enough. And so all you have to do is up the radiation, and then all of a sudden you can kill anything with enough radiation, right? It's like, except for maybe Bruce Banner with the gamma rays. So here's what we thought. So, solitary renal cell, local control is critical. So we want to make sure that we can control this disease, particularly if we only think it's at one location. But surgical resection, like you guys talked about, we're going to do an en bloc vertebrectomy. Holy moly, that's a pretty big deal. And I don't think a lot of people have a lot of experience with that. But the guy does have severe mechanical back pain. So could we do some stabilization and think about radiosurgery? Can we do something else? We do know that solitary bony metastasis, the survival rates are substantial if we can get good resection from those levels. So We know that people do better if we can take that out of the way. And here was kind of a cool slide that I stole that talks about proposed algorithm for treatment with patients with renal cell and bone metastasis. With oligomets, they really say, listen, if there's some ability to get some definitive therapy, maybe we can remove that piece and get some sort of cure. I think like most of, how that being said, I think that there's no such thing as solitary metastatic disease. I think it is all everywhere, someplace, and it's just you haven't found it yet. And so I think this is a very rare disorder. I think most of this is the rest of this. It's going to be multilocular disease. You need to think about surgical resection if you have the institutional bias and ability to do it. And then you also need to think about then other treatments. The good news is that things have changed dramatically for renal cell. There's these tyrosine kinase inhibitors, bisphosphonates have made a huge difference in terms of survivability and long term. So, you know, I probably didn't say, but my first disclosure that is important is that I'm a surgeon, right? And so I like to think about taking things out. So I didn't want you guys to think that I was a chicken. And so this is what I decided to do. I talked to the patient. He really wanted this, you know, we said, boy, there's a chance this could be curative. I think he really latched onto that, and the oncologist latched onto that and made this discussion of XRT and everything else a little bit more challenging. And so what we planned on was an en bloc vertebrectomy. Actually, the nice thing about this renal cell is actually it's in the right, easy location. If there's an easy location for an en bloc, this is in the front. It hasn't really escaped out of the vertebral body. It's not in the canal. And so this is about as easy as it gets. And so we embolized it and planned for an anterior support and then post-op with radiosurgery, tyrosine kinase inhibitor, and then a bisphosphate for therapy. And so just to walk you through the case here, we did, so first we embolized that T11 level. We then did our stabilization. This was, I did this about 10 years ago. So we did not have carbon fiber cages or anything else. So this is just a piece of allograft bones because I wanted to be able to image it well afterwards to look and see if there's any local recurrence. And here's intraoperatively what it looks like. And so we did a bilateral nerve root ligation, worked from the right side, left side, and then rotated out this en bloc vertebral body. And so post-op, pain improved. Actually, it's amazing. You know, you do this, this guy is otherwise pretty healthy. And man, he was like walking around the ICU, ready to leave the hospital on post-op day 2 or 3. It was kind of amazing. You know, I remember the resident looked at me and he was like, does this guy know what we just did to him? Because he should not be looking as good as he's looking right now. And so he didn't have any neurologic deficits. He felt really good. And then we planned for adjunctive radiation and tyrosine kinase with bisphosphonates. And so we're able to resect that. Like, unfortunately, like all things, if you follow patients long enough, and so as I was looking for things, unfortunately, he developed pulmonary disease, and he had progression of disease and metastatic disease, and he only survived 1 year post-op and succumbed to his multifocal renal cell afterwards. So unfortunately, we went for cure. We luckily didn't hurt him, but I was certainly not able to cure him of his disease, unfortunately.
Yeah, Eric, that's also a great case, and you know you chose a certain option that made sense to you, to the patient, to the oncologist, to everybody around you, which is great. So obviously, you know, and a great surgical outcome. You know, I do want to stay honest about our participants. A couple of really good questions, so I'm just going to fire them at you, Eric, if you don't mind. Do you use TXA in cases of where you expect a lot of bleeding?
Yes.
Okay. Question number 2, do you use Cell Saver?
No.
Okay. And
there's a ton of debate with that, with the Cell Saver stuff. I have the oncologist tell me it's okay to use it. It just seems to me as it just makes me nervous. The idea of it going in there and getting washed around, and unless there's a, you know, if it's a Jehovah's Witness with renal cell, then maybe I'm using Cell Saver. But other than that, I would rather just get blood from the blood bank and not risk it.
Got it. Got it. That's perfect. All right. So we literally have a couple of minutes to go. I need a favor from both of you, from both John and Eric. Now, remember, everybody here with us, just stay an extra few minutes so you can fill out the survey and get your CME credit. But I'd like to, I'm going to start off with this. I need John and Eric to, based on your vast experience in spine tumor give a one-liner. If you were to, if somebody says, give me a one-line tip on everything that you've done in spine tumor surgery, what's the one tip you can give us? And I'm going to start. So for me, it's what I said earlier. In spine tumor surgery, immediate fixation is for me very critical. Fusion is important, but immediate fixation, if it means going long, 2 above, 3 above. But I see a lot of these patients with mechanical pain, and I've always never regretted providing robust fixation up front. Potentially at the expense of fusion or expensive bone grafts, if you will. So that's my tip. Eric, give us a one-line ending note to our participants.
I think you're not going to cure anybody's disease with these treatments, and so that should never be your goal. The idea is really keep to your principles, and so if patients have neurologic deficits, decompress them and give them some stability. If they have mechanical back pain, you do have a little bit of time. You don't have to go rushing into anything, and just be very thoughtful. Again, people really trust. They already have cancer. What you don't want to do is give them cancer and a bad operation or a neurologic deficit or something terrible like that. So just be thoughtful and be cautious.
Thank you, John. A one-line tip for everybody here.
Yeah, I think I would say that it's all about, I would say in all spine surgery, but I think especially in metastatic disease, it's really should be emphasized the shared decision making. I think that was one of the things that came up earlier. We can follow all kinds of, algorithms, frameworks, gnomes, predictive analytics. That's really the hot trend now, machine learning. But in the end, these are all flawed to a certain extent. And so I think that we can assess stability and, we can do a good neuro exam. But in the end, these patients, we're seeing these patients at a very difficult time. And, we really don't know them, and they've really kind of gone through a lot with their oncologists and their family. So I think having that perspective and getting their input in terms of what they want to do, how they want to approach it is very important.
Wonderful, wonderful. Well, listen, thank you both, Dr. Kleinberg, Dr. Shin. Thank you to our participants. Great questions. I think it was a great discussion. It is the top of the hour, on the hour, and thank you to Mark Ritchie, Ron Costello, everybody from AO Spine for putting these webinars. So thanks to everyone. Have a safe day or evening, and stay safe and Happy New Year. Thank you all.